Ladies and gentlemen, we move on to the last lecture of this session that features Rosuvastatin and cardiovascular disease protection, status 2016. For the next 20 minutes, I'd like to invite, with the permission of the chair, Professor Asha Moorthy, Head Department of Cardiology at Savitha Medical College from Tandalam in Kanchipuram, peripheral Chennai. And following that, we'll have 10 minutes of discussion with the chairman's comments. Professor Asha Moorthy, please. To help Professor Moorthy be on time, we have a timer adjacent to the plasma screen on the podium. I would request her to kindly pay attention. Thank you very much.
Good morning, everybody, chairpersons, ladies and gentlemen. At the outset, first of all, I'd like to thank Dr. Chopra for giving me this wonderful opportunity for this presentation. And I'm going to speak on Rosuvastatin and cardiovascular diseases protection, status 2016. There's a burden of risk factors in India not borne by the conventional risk factors of diabetes, hypertension, and mixed dyslipidemia, but also the elevated inflammatory markers, which all together give rise to endothelial dysfunction, activation, decomposition, and altogether cause a cascade of atherosclerosis. The statin, which was thought safer, is we thought, as the Lancet editor, Dr. Richard Burton, has told, the editor of Lancet, that the potential side effects of statins are largely exaggerated and the cholesterol reducing tablets are safe and effective. A major medical review which was found recently, it was put in Times of India. I just wanted to give. And there's lots of inertia by the general practitioners to give higher dose of 40 milligram because of the fear of the side effects, myopathies and all, which I'm going to tell in the following statistical analysis, that how the patients with the higher dose well tolerate even in Indian scenario. Statins are the cornerstone for the secondary prevention of cardiovascular diseases. There's a perception among the clinicians that the Rosuvastatin has no data for the secondary prevention. It is unlike. Here, so we discuss currently all the available statistical analysis, the various studies, the role of Rosuvastatin in acute coronary syndrome and stable ischemic heart diseases. Rosuvi's Indians trial, which was the largest Indian trial which was undertaken in the major metropolitan cities. More than 25,000 patients were included. It came in International Lipidology Journal in 2012, in which a suitability was found of all the Indian patients with a larger dose of 40 milligram of Rosuvastatin in patients with coronary artery disease. Dyslipidemia are categorized into circulating dyslipidemia and vessel wall dyslipidemia. So as I told in the previous slide, that all the conventional risk factors plus the elevated inflammatory markers, what they do is they decrease the endothelial dependent vasodilation. With the result, there is an increase in the growth factors, increase in the macrophagic stimulation production, and all these factors combine and give rise to a dyslipidemia, which can be documented also by the vascular MRI. Acute coronary syndrome, which has a true component, thrombotic and ischemic component, and you can find that the atheroma volume can be significantly reduced by giving HDL infusion, which is the futuristic approach, and by the plaque stabilization by the higher dose of statins. So what are the benefits in statins in acute coronary syndrome? Now one is got a pleiotropic action. Number two, it decreases the LDL, circulating LDL dyslipidemia. So with the result, there is a decrease in thrombogeneity of the blood. So how does it reduce the pleiotropic action? Is by improvement in the endothelial dysfunction, which I told in the earlier slide, that how the cascades of atherosclerosis give rise to a stage of plaque formation. Increased nitric oxide viability, antioxidant properties, inhibition of the inflammatory response. So altogether, it causes plaque stabilization and it decreases the thrombogeneity of the blood. PRISM trial is one of the largest trials in which they found that the withdrawal of the statins increases the event rates in patients with acute coronary syndrome. And you can see in the graphic representation, when the statins was continued, the event rate was less. When it was no statins were given, still the event rates was higher. And when the statins were suddenly discontinued due to some reasons, they found the event rates to be very higher. To document this, there's a lots of randomized trials earlier of statins and ACS, which was Miracle Trial, Florida, Prove It, A to Z, PAC, Princess. All these trials proved The largest was Armada trial of acute coronary syndrome 2007. So including to this, all these trials are documented there is the utility of higher doses of statins in case of acute coronary syndrome. The safety of aggressive lipid management was found that treating more than 1,000 patients with higher dose of statins would cause only lesser amount of major adverse cardiac events. And it was almost less than 0.6% severe musculoskeletal toxicity, and serious hepatic toxicity was less than 1.3%. So you could see that the percentage of the side effects is not that much as expected as people think, or as the general practitioner think of it. So your question may be, is the target level of less than 70 or less than 50 is safe? Yes. It has been proved by TIMI-22 sub-study JACK 2005 that about 1,825 patients with 4 months of trial, they were found that LDL has come down to 100 and has been very much beneficial for all the patients who were submitted with high dose of rosuvastatin. Also to prove it, heterozygous hypo-beta-lipoproteinemia, they found the triglyceride as low as 80 milligram and LDL-C as low as 30 milligram. This condition was associated with longevity, presumably because there was absence of atherosclerosis and no side effects of low LDL was noted. Rosuvastatin versus the atorvastatin in ACS patients, the number of studies has been done. LUNA study, 825 patients with ACS, they were submitted to, one group submitted to rosuvastatin 20 milligram and 40 milligrams atorvastatin for 12 weeks, and 2 primary endpoints and secondary endpoints were observed, and they found that LUNA study in LDL-C, it decreases the LDL-C better than atorvastatin 80 milligram in ACS patients. And similarly for non-HDL-C, it was found that rosuvastatin 40 is more effective versus atorvastatin 80 milligram to decrease the LDC and non-HDL-C in ACS patients. Rosuvastatin in ACS CV outcome was found that those patients with the control trials who were not submitted to rosuvastatin had increased primary endpoints of myocardial infarction, stroke, death and revascularization rates was higher as compared to those groups who had a loading dose of rosuvastatin. So this was the inference that those patients who had a control had a higher primary endpoints of these major cardiovascular events compared to those patients who had a rosuvastatin. So the loading dose before PCI significantly improved the 12 months clinical outcomes in ACS patients undergoing PCI. Statin trial, a rosuvastatin versus atorvastatin in stable coronary artery disease. I'm telling you about stable coronary artery disease. So in this group of patients, the statins trial has proved that rosuvastatin was more effective than atorvastatin for LDL-C, non-HDL-C and triglyceride lowering and for HDL-C increase. A steroid study design was given to see the angiographic coronary artery disease of more than 20% luminal narrowing, in which no total number of 507 patients were included, and they were given a rosuvastatin of 40 milligram for 24 months. And what they found is significant change in the atheroma volume of the target vessel. Number 2, the total atheroma volume in the most diseased patients of more than 10 millimeter segment had drastically come down. So this was outcome. The rosuvastatin was found to be more effective than atorvastatin in decreasing the total atheroma volume reduction and the plaque regression. Artemap study was used in which atorvastatin 20 milligram and rosuvastatin 10 milligram for mild atherosclerotic plaques. So the inference was greater regression of mild coronary atherosclerotic plaque than atorvastatin 20 milligram. So the concluding remarks of this rosuvastatin in patients with the stable coronary plaques are that they are superior to atorvastatin in the reversion of coronary atherosclerotic plaques. Prato ACS, these are the group of patients in which they had an underlying chronic kidney disease. So you can assess that those patients with chronic active disease, you may think that you should not load with a higher dose of statins. But the result is the efficacy of loading dose of rosuvastatin in contrast induced acute kidney diseases. We have found a very efficacy of role of giving rosuvastatin with 20 milligram and even also 40 milligram for 30 days, which was presented in the ACS 2013 March. Roma trial for periprocedural myocardial infarction. That is those patients who have been submitted for primary angioplasty or for any procedural, for facilitated angioplasty or for all these groups of angioplasty. It was found that the objective was to study with the 40 milligram rosuvastatin in reducing the periprocedural myocardial necrosis and major cardiovascular or cerebrovascular major adverse cardiac events or cerebrovascular evidence in elective PCI patients. The inference was that rosuvastatin significantly reduced the periprocedural myocardial necrosis in elective PCI unstable angina patients. So what are the guidelines given by the American Heart Association, guidelines given by the European Society of Cardiology? All current guidelines for management of ACS and stable ISD mentions a moderate high intensity statins therapy, and the option is the rosuvastatin is an option for both moderate 5 to 10 milligram and high intensity 20 to 40 milligram statin therapy. So these are the guidelines which has been given by 2013 American Heart Association guidelines for hypercholesterolemia, giving high intensity statin, atorvastatin 80 milligram, rosuvastatin 40 milligram, and other moderate intensity statin like atorvastatin, rosuva, simva. In all this group we are given lower dose of statins. The guidelines for the 2012-2013 has been revised for non-ST elevation MI guidelines. They say the high intensity statin therapy should be initiated or continued in all patients with non-ST elevation ACS and no contraindications to it. So absolutely, even in the chronic kidney disease or even with the contrast-induced nephropathy, you found that we could get a safely higher dose of statin, which comes, and the indication comes on the level of evidence A, group 1, class 1. The European Society of Cardiology 2015 also for non-ST elevation given the guidelines that the high intensity statin therapy is a advisable regime for reducing the LDL-C, which can be reduced more than 50%. So what is the take-off message, ladies and gentlemen? Rosuvastatin is the most effective statin for LDL-C and non-HDL-C lowering. Rosuvastatin has been used in the clinical trials for lipid lowering, atherosclerotic plaque regression, as well as cardiovascular outcomes up to 1 year. All international guidelines recommend use of moderate intensity statin for secondary prevention, and rosuvastatin can be used as high and moderate intensity statins. There is also evidence and guidelines suggested that it can be used for the secondary prevention for both ACS as well as for the stable ISD. Drama makes everything possible, life makes everything work, love makes everything beautiful, smile makes all the above. So keep smiling, as our Shivani has given a beautiful lecture in the morning. So keep smiling. The futuristic approach is to give IV statin. It may come in near future. And thanks for the patients listening. I thank chairpersons and ladies and gentlemen for the kind attention. Thank you very much.
Thank you, Professor Moorthy. Please join the chair. Ladies and gentlemen, we'll have the next 10 minutes for the chairman's comments and questions from the floor. Over to the chairpersons. Thank you.
Good morning, ladies and gentlemen, and let me extend a warm welcome who joined session late. I'm going to summarize on atrial fibrillation. As we all know, atrial fibrillation is increasing, and it's the commonest tachyarrhythmia which we all face in our day-to-day clinical practice. We are seeing more and more younger patients with atrial fibrillation due to the rising incidence of multiple risk factors, especially obesity, diabetes, hypertension, and obstructive sleep apnea. The moment we establish that our patient has got atrial fibrillation, of course, we have to decide rate versus rhythm strategy, and then subsequently, irrespective of paroxysmal, persistent, or chronic atrial fibrillation, we should stratify thrombotic risk by CHA2DS2-VASc score, as well as bleeding risk by Hess blood score. And as per guidelines, we should decide which preventive strategy in the form of anticoagulant have to be utilized for the prevention of a stroke. And as we have already had Professor Ray emphasizing, 2016 ESC guidelines have emphasized that NOACs are preferred than over warfarin, although it's a sweeping statement. And to decide which NOAC for which patient, of course, you have to take consideration of thrombotic risk, bleeding risk, associated risk factors, comorbidities, and then decide which NOAC suits best for the patient sitting in front of you. The most important thing to remember is always keep a holistic approach even for patients of atrial fibrillation. Never forget to emphasize modification of risk factors. As we have seen in Orbit-AF trial, a structured cardiac rehabilitation program resulted in reduction of reablation in atrial fibrillation. So never forget about the modification of risk factors in atrial fibrillation patients. Now the last is, are we doing enough for our patients? Answer is certainly no. As emphasized by Professor Ray, only 50% of the eligible patients are getting anticoagulation. So we are not doing justice. We should ensure that every eligible patient should get anticoagulation, and 1/3 patients in registry are getting just aspirin when they are eligible for oral anticoagulants. So that should not happen. Third, when we are giving these drugs, of course, the patients have to be monitored, as even with the NOACs, adherence over long term is only 1/3 to 1/2. And the moment they stop the drug, thrombotic and stroke risk increases. So we should ensure that our patients are adherent to our drugs. Thank you.
Well, thank you for the nice comments. Actually, elegant presentations by all the three speakers here and all of you, and Dr. Das and Professor Ray. And the only thing now, we should invite some quick questions from the audience. Yeah. Do you have any questions?
Can I ask a question?
Yes, sir.
Just a question for the speaker, Professor Asha, and for the experts, the chairpersons. My question is regarding the dosage of statin in chronic ischemic heart disease. In acute coronary syndrome, preparatory to PCI, you gave large doses, 40, 80, and this. But our colleagues gave, even in cases of a prolonged, 40 mg or so, which I beg to differ. I usually control my patients in 10 and 20, but with diet and exercise program. I want to know your comments on that, because giving high doses, we must tell them about lifestyle, why they should take high doses. Many cardiologists in my city, they gave 40 to a person who is just a chronic ischemic heart disease. Sir, your opinion?
I think things are very clear. If you look at the landmark trials for secondary prevention, be it 4S or be it others, the curves for cardiovascular events start separating 18 months. So if you are using statin for secondary prevention in the conventional dose, as you are saying, the benefit will start after 18 months. If you look at the curve separation in primary prevention trial, Voskop's and others, the curve starts separating after 9 months. But if you look at high dose versus low dose, like TNT, the curve starts separating very early, the magnitude of the benefit is more. So if you want your patients to have the benefit of statins early, the high dose intensity statins are preferred. That's why all guidelines for secondary prevention say high dose statin irrespective of even the LDL levels.
Professor Manoria, I beg, this is the point which I was not raising, that we go on guidelines of American Heart Association. What are our guidelines? You tell me your guidelines.
See,
I can give you my guidelines. In my practice, 50 years of practice.
Don't have any long-term data.
It is guidelines is misguiding us, I can tell you. Indians.
See,
Or
it's
Indian
two
patients.
Indians. But the basic fact remains that the curves, all trials universally all over the globe,
Not
if you
in
start
India.
low dose, the curve separate after 18 months, you can see the curve separation any. For primary prevention separates after 9 months. That is the basic fact which has not been very clarified even by the guidelines, but the recommendation stands high dose statins throughout the globe.
Sir, my question is whether we should give statins for lifelong, or should we give it for some time and then advise patient to follow diet and exercise.
Dr. Moorthy, you want to reply? Or?
Doctor, this is WHO recommends that statins should be given lifelong. Even you should add statins in the water.
It's okay. That is a recommendation.
So,
but what is your?
the studies has to be there,
What is
and I
your-
recommend it for lifelong. Those patients who have been diagnosed with clinical atherosclerotic clinical heart disease. They have to give in high dose, but not high dose a long time. They have to minimum titrate after 12 to 18 weeks. First, initially start with a higher dose, and then you can taper it to 5
A
milligrams.
slim Indian farmer who has myocardial infarction, should he go for lifelong statins?
I think we have some answers for primary prevention. The Voskop's long-term 20 years follow-up showed that you take statins and enjoy the benefit for the next 20 years. We have limited data in secondary prevention for 4S and from other trials, so that there is a legacy effect of statins also. But what is very important is if your risk remains high, even after taking statins, you should continue in higher doses compared to a patient whose risk has been minimized. You may opt for this strategy, but if you're tolerating statins better, no problems, it is desirable to continue.
Thank you, sir.
I would like to comment on your, very briefly. You asked that statin should be given lifelong. Answer is certainly yes, no doubt about it. Dose of a statin will keep on varying depending how your patient is reacting to the overall risk factor profile. Suppose you started with a high dose and he has achieved the goal. But if he modifies his lifestyle, his weight is down, he has modified his diet, he is carrying out stress management, his blood pressure is controlled, overall risk profile is certainly improved. You might be able to achieve that goal even with a lesser dose of a statin. Try to maintain that dose of a statin which is maintaining the goal with that maintained lifestyle lifelong. That has to go on.
Sir,
Okay,
my question to all the cardiologists sitting on the dais is, sir, we are emphasizing only on the LDL cholesterol, which we consider as a bad cholesterol, and we are only after reducing the bad cholesterol level, LDL cholesterol level. Is the risk reduction with the lowering of LDL cholesterol, whatever is the standard set in by the American guidelines and all, is 100%? It is only LDL cholesterol which is responsible for causing coronary artery disease. There are so many other risk factors also, like triglyceride and a diabetic state of the patient. And I would agree with my honorable sir, Brigadier Sanani, that we must have studies which have proven effective in our Asian population. We should not rely only on the American studies. So this point needs to be clarified, sir, because it's not only the statin which works in reducing the coronary artery disease. We are addressing a conference where we are discussing about the primary prevention and the lifestyle measures, and we are at the same time we are giving so much of importance to the reduction of LDL cholesterol only, sir.
I think the basic fact you must understand, what goes inside the vessel wall is only ApoB. And if you look at the ApoB structure at any level across the board ApoB, 90% of ApoB is constituted by LDL. So there's only a 10% which can be contributed by VLDL. So you are indirectly asking the role of fibrates. Fibrates may play a minor role in the subset of patients where LDL goals have been achieved and you have a non-HDL goal which is not targeted. But the fact remains 90% of ApoB across the board is LDL. So LDL lowering is the crux of the matter. Only 10% remains for VLDL. The second thing is that lipid control accounts for 50% of cardiovascular risk. The remaining 50 is by blood pressure, smoking and others. So at the most, you can control 50%. 25% is already contributed by statins. The remainder 25 PCR, SK9 are being evaluated. So you can decrease at maximum 50% of the cardiovascular, not 100%. We are not talking statins for 100%. Only for the dyslipidemia component, which is one of the components of the atherosclerosis.
Thank you very much, Mr. Chairman. We have totally run out of time for discussion.
What is the maintenance dose of
discussions in
Rosuvastatin
press.
lifelong? What is the maintenance dose of Rosuvastatin lifelong?
I think it has already been discussed. If you are a high-risk individual, after whatever has been done, you continue with the high dose for secondary prevention.
Those 40 milligram?
Yeah.
I want
Yes, 40 Rosa, Atorva 80. I think the debate between Atorva and Rosa is gone. Both are effective. Both can be used alternate, except in some subset of patients like renal failure.
Thank you. Thank you very much, Mr.
So is
Chairman.
it
We
LFTs
have to
or
move ahead
liver function tests are
with the
necessary?
next set of proceedings. Thank
Liver
you.
function tests are necessary in between? LFTs or
Liver
anything?
functions not necessary.
Yeah, we request delegates to kindly interact with the speakers in person. They are available at the end of the sessions. We'd like to thank our chairpersons for the opening session on atrial fibrillation track, New Frontier.